Welcome to the deep dive. We're doing something a bit different today, something really fundamental.
Yeah, going back to basics.
Exactly. We're pulling back the layers on the basic science that, really underpins all of vascular surgery.
Hmm.
We're looking specifically at those foundational principles laid out in the early chapters of Rutherford's textbook, chapters 1 through 10.
Right, the ones that sort of
Mhm.
form the bedrock. It's easy to forget how important they are day to day.
Totally.
And we're not just, like, revisiting old ground here. The goal is really to crystallize why this initial framework,
Yeah.
covering everything from, research methods, vessel anatomy, atherosclerosis, IRI, angiogenesis, all that stuff.
Right. Hemodynamics, venous disease,
Mm,
the whole gamut.
exactly. Why it remains absolutely essential. For surgeons at every stage, trainees, experienced folks, everyone.
It's the why behind the how.
That's a great way to put it. It really is.
Okay, so let's dive right in then. Chapter 1, Epidemiology and Research Methodology. It's kind of amazing how the basic questions haven't changed, right?
You mean like who gets vascular disease, what causes it, what happens to them?
Yeah, exactly. Those core questions have driven research from, well, forever.
What has changed dramatically is how we answer them.
Mm.
I mean, think about it. We've gone from simple observation
Mm.
to analyzing these huge international registries using machine learning.
Yeah.
It's incredible.
The tools are way more sophisticated now.
But the underlying principles,
Yeah.
still the same. You need good data. You need sound analysis, clear interpretation. That hasn't changed.
And for a busy surgeon trying to make sense of a new paper, understanding how they gain those results is key, isn't it?
Absolutely crucial. You need to know if the findings are reliable.
And the chapter makes a great point. All research starts with a clinical question. That thing you see in clinic or in the OR that makes you go, why?
Right. Why does this graft work better? Why do some patients progress faster?
Yeah.
That curiosity drives it.
And the type of question dictates the study design. Observational versus experimental.
Precisely. Take the EV air versus open repair debate. We've learned so much from big cohort studies.
Like using Medicare data or VQI.
Exactly. Giving us those real-world insights, long-term outcomes, patient selection nuances. Sometimes survival is similar, sometimes...
Secondary interventions differ.
Right. And knowing if that cohort was prospective or retrospective, it matters for how much weight you give the evidence.
And for those less common conditions, the case control study is still really useful, right? Comparing affected patients to controls.
Definitely. Helps pinpoint potential risk factors or associations.
Then you have experimental studies. The RCT, the randomized controlled trial, is still kind of the gold standard for
Yeah.
causality.
It is, when you can do it. Think about best CLI, comparing bypass versus endo for critical limb ischemia.
Yeah, a situation where there was genuine disagreement among experts.
That's clinical equipoise. It justifies randomization. Ethically, you need that uncertainty.
But RCTs aren't perfect, as the chapter points out. They're expensive, sometimes impractical.
Enrollment can be tough getting a diverse group.
And do the results from a high-volume specialized center always apply to, regular practice?
That's the generalizability question. It's a real limitation sometimes. Plus, issues with intent to treat analysis, power calculations, it gets complicated.
Which is why being able to critically appraise the literature is so vital.
Absolutely. And when individual trials are small or maybe show conflicting things,
That's where meta-analysis comes in, combining results.
exactly, you pool the data to increase statistical power, hopefully resolve inconsistencies. But you have to be careful.
How so?
Well, you need to assess heterogeneity. Are the studies similar enough? If they're too different, combining them, it doesn't make sense. You need to think about fixed versus random effects models.
Got it. The chapter also talks a lot about bias, things that can skew results.
Yeah. Random error is one thing, just chance variation. But systematic error, bias, that's different.
Like selection bias, who gets into the study?
Right. Is it self-selection? Researcher bias? Or information bias, how the data itself is collected? And then there's confounding.
Ah, the hidden variables that mess things up.
Exactly. That's where things like propensity scoring come in handy for non-randomized studies.
Trying to statistically balance the groups after the fact?
Sort of, yeah. It helps adjust for known confounders, the things you measured. But it can't account for what you didn't measure. That's the limitation.
Makes sense. Then we get into the actual stats, descriptive stats first.
Yeah, just describing your study sample. Continuous variables, categorical, ordinal, helps you see who you're actually studying and if they're comparable to your own patients. Generalizability again.
And then regression analysis. Linear, logistic.
Right. Building models to understand relationships. How does variable X affect outcome Y? Those regression coefficients, the betas, tell you the strength and direction.
And goodness of fit, like R squared.
Yeah, how much of the variation your model actually explains. Adjusted R squared is often better. It reminds you, correlation isn't causation.
Definitely. And for us, survival analysis is huge.
Oh, absolutely. Kaplan-Meier curves, log rank tests, Cox models, bread and butter for looking at time to event data.
Graft patency, amputation-free survival.
Exactly. And understanding censoring when patients drop out or the study ends is key to getting the analysis right.
It seems complicated, but essential.
It is. And it's not just about survival rates. What about quality of life?
Right. The utility measures, HUI, EQ, 5D, quantifying how patients feel in different health states.
Which is crucial for decision analysis, where you're formally weighing the pros and cons of different treatments.
And that leads straight into the economics, doesn't it? Cost-benefit, cost-effectiveness.
Yep. Balancing health outcomes against costs. It's complex, often controversial, but we need to understand the principles to participate in those discussions about value and resource use.
Finally, the chapter wraps up with levels of evidence and grades of recommendation. That hierarchy.
Yeah, table 1.1 and 1.2 in the book. From RCTs and systematic reviews down to case reports and expert opinion. It's the foundation of evidence-based practice, guiding how we apply research to patient care.
Okay, so that's a solid grounding in how we generate and interpret knowledge. Really crucial stuff.
Couldn't agree more.
Let's shift gears now and look at the actual structures we work on, the vessels themselves. Chapter 3, structure of the vessel wall.
Right, and the detail here is just incredible, starting right down at the capillary level.
The exchange sites.
Yeah, nutrient and waste exchange. And even there, the endothelium isn't uniform. Continuous, fenestrated, discontinuous. It's adapted for different tissues. Amazing design.
Then moving up, venules, veins, key differences from arteries, right?
Big time. Veins are much more compliant. They can hold a lot of blood without a big pressure jump.
And that adventitia, it's packed with collagen. Makes sense for a low-pressure reservoir system.
And the valves, often
Yeah.
overlooked, but critical. Absolutely. Preventing backflow, especially in the legs against gravity. The chapter really links valve problems, fewer valves, structural changes, maybe MMP involvement directly to CVI and varicose veins.
We shouldn't forget lymphatics either.
True. Less defined layers maybe, but those lymphangions, the contractile segments, they're vital for fluid balance.
So the general structure, intima, media, adventitia, that's common ground.
Yeah, but those elastic laminae, internal, external, much
Yeah.
clearer in arteries, built to handle higher pressures.
And the endothelium, that single-cell layer lining everything. It's not just passive wallpaper.
Far from it. It's regulating vasomotor tone, involved in clotting, permeability, cell growth, immune responses. It's incredibly active, responding to all sorts of signals, physical forces, chemicals, immune mediators.
And the adventitia, the outer layer, turns out it's pretty dynamic too.
Yeah, it's got progenitor cells, keratinocytes, involved in vessel formation. And that fat around vessels, the PVT, is like an endocrine organ itself, influencing things.
So comparing veins and arteries again, thinner walls and veins.
Thinner walls, more collagen, less elastin. That's key. And the vein intima is geared towards the venous environment, making things like PGI2 and NO.
Vasodilators, platelet inhibitors.
Right. Helps keep things flowing smoothly at low pressure, but put that vein in the high-pressure arterial system, like a bypass graft.
It's not adapted, can lead to that neo-intimal hyperplasia we see.
Exactly. The environment matters. And then you have the molecular markers.
Like fingerprints for vessel type, Ephrin B2 for arteries, AFB4 for veins.
Prox1 for lymphatics, yeah. Cable 3.2 lays those out. But what's really cool is the plasticity.
How vessels can change.
Yeah. It's not just the markers. The actual forces hemodynamics play a huge role in differentiation and how vessels behave in adults.
Like vein grafts starting to act a bit more arterial. Or AV fistulas.
Precisely. They adapt. Which brings us to those forces. Cyclic strain from blood pressure, shear stress from flow.
How do they influence things?
Profoundly. They affect protein production, cell shape, migration, proliferation, everything.
Let's talk shear stress first, that force along the vessel wall.
Right. There's a normal range in arteries. Vessels try to maintain that. Acute changes might trigger vasoactive stuff.
Like NO release for dilation.
Yeah, flow-mediated dilation. Chronic changes lead to actual remodeling. Low shear stress, on the other hand, is generally bad news.
And how do the cells sense this force?
Mechanotransduction. Through the cytoskeleton, primarily. It converts that physical pull into biochemical signals inside the cell. It's fundamental.
Then there's cyclic stretch, The pulsing from the heartbeat.
Yeah, that affects cell orientation, growth. Interestingly, some baseline stretch seems needed to keep smooth muscle cells quiescent, kind of in a non-proliferative state.
So understanding the wall structure and these forces, it sets the stage for understanding disease, right?
Absolutely. You can't really grasp atherosclerosis or other problems without this foundation.
Okay, perfect segue. Chapter 4, atherosclerosis, something we deal with constantly.
Every single day. The chapter defines the plaque really well, that necrotic core, the lipid-rich part.
The atheroma, like gruel.
Yeah, vivid term. And the fibrous cap over it. Plus smooth muscle cells, inflammatory cells.
Yeah.
It's a mess.
And the stability really hinges on that cap, doesn't it?
Hugely. Its thickness, its composition. Are there foam cells infiltrating it? Is it getting thin? That's your thin cap fibrotheroma, the really vulnerable plaque.
It's fascinating how our understanding of how this starts has evolved, the lipid hypothesis.
Right, back to cholesterol research, finding LDL, HDL, realizing cholesterol transport was key. But it's way more complex than just total cholesterol.
It's about the types of lipoproteins, how they're handled.
Exactly. Then came the response to injury idea.
Endothelial damage kicking things off.
Yeah, could be mechanical stress, toxins, infection, inflammation.
Yeah.
Leads to platelets sticking, LDL getting into the wall, smooth muscle cells migrating and proliferating.
Building that neointima. PTGF was a big discovery there.
It was. And now the inflammatory response is seen as absolutely central.
Monocytes getting recruited.
Pulled in by adhesion molecules, chemokines like MCP1, they turn into macrophages, gobble up lipids, become foam cells.
T cells involved too.
Yeah, releasing cytokines, MMPs.
Hmm.
There's complex signaling like CD40. Even mast cells play a role. It's a whole immune battleground in the vessel wall.
And macrophages aren't just sitting there, they're active in thrombosis too.
Especially in plaque rupture. They churn out MMPs that chew up the collagen in the cap, weakening it.
And what about those cholesterol crystals, the inflammasome connection? That's newer, right?
Relatively. The idea that these crystals trigger the NLRP3 inflammasome, which then pumps out IL-1 beta and IL-18.
More inflammation.
Exactly, driving the plaque growth. And the CANTOS trial provided human evidence for that pathway. Pretty significant.
Why do plaques seem to love certain spots, like branch points?
Good question. The chapter suggests local hemodynamics, the flow patterns in those areas, likely play a big role. Disturbed flow.
Makes sense. The chapter touches on plaque regression too, but really focuses on the bad stuff, thrombotic complications.
Right. Physical disruption, usually the cap fracturing, seems common in coronaries. It's a mix of mechanical stress and biological weakening.
And once it ruptures, boom!
Exposure to thrombogenic stuff like tissue factor, platelets pile on, coagulation cascade kicks in. You get thrombus. Often it worsens the stenosis rather than blocking it completely initially.
And risk factors like smoking, diabetes, high LDL make that thrombus formation more likely.
Well, definitely amplify the risk. But rupture isn't the only way clots form.
What else?
Interplaque hemorrhage, especially in carotids. Fragile new vessels, vasa vasorum in the plaque, particularly with diabetes. Superficial erosion of the plaque surface.
That's linked to diabetes too, and seen more in women.
Yeah, endothelial apoptosis, myeloperoxidase seem involved, and sometimes erosion over calcified nodules. It seems the dominant mechanism might vary by artery bed.
Interesting. Lipid cores may be more key in coronary carotid, fiber stuff in femoral?
Something like that. And it explains why therapies targeting thrombosis like low-dose anticoagulants in COMPASS or Voyager show benefit across different vascular beds. Thrombosis is a common endpoint.
So the million-dollar question, can we spot these vulnerable plaques before they cause trouble?
That's the goal. IVUS gives great anatomical detail plaque size remodeling. Is the artery bulging out to compensate? Are there thin caps?
What about function? Endothelial function?
Yeah, things like flow-mediated dilation. It's a surrogate marker, often impaired when there's inflammation or risk factors. It predicts adverse events.
And molecular imaging, peeking inside the
A
plaque.
very exciting area, using MRI or CT contrast or even ultrasound with targeted microbubbles to see macrophage accumulation,
Yeah.
VSAM1 expression, inflammation hotspots. Huge potential for risk stratification.
So understanding atherosclerosis, initiation, progression, complications, it's just fundamental for us.
Absolutely. It impacts everything we do, from diagnosis to treatment choices to long-term follow-up.
Okay, so plaques block things. What happens when we unblock them or when flow is interrupted for other reasons? Chapter 6, ischemia reperfusion injury, IRI.
Right. A huge topic, relevant in so many situations we manage.
Like a post-bypass, stunning, acute limb ischemia.
Compartment syndrome, aortic clamping, mesenteric ischemia, shock, even MODS, The list goes on. The chapter even mentions youth maybe being subtly protective, which is interesting.
The pathophysiology is complex, isn't it? Starts with the endothelium taking a hit.
It's very vulnerable. Lack of oxygen, nutrients. Cells run out of energy, membrane potential changes. They start releasing pro-inflammatory stuff.
And the connections between cells loosen up.
Yeah, tight junctions, adherence junctions get disrupted, leads to increased permeability, leaky vessels.
So fluid leaks out, causing edema.
Exactly.
Right.
And paradoxically, when you restore flow reperfusion, things can get worse initially.
How so?
Introduction often tanks, so you lose vasodilation. But production of reactive oxygen species, ROS, goes way up. Creates this prothrombotic inflammatory state that can actually impair capillary flow restoration, the no reflow phenomenon.
Then the white blood cells rush in. Neutrophils.
Big players.
Yeah.
They get activated, contribute to what's called sterile inflammation. They generate more ROS via enzymes like NADPH oxidase, myeloperoxidase.
And release stuff that damages tissue, MMPs.
Yep, matrix metalloproteinases that degrade tissue. And during reperfusion, they stick to the activated endothelium, ICAM1, BCAM1, E-selectin are upregulated and migrate out into the tissue, drawn by chemotactic factors,
Making the inflammation worse.
perpetuating the cycle.
Yeah.
The chapter details their arsenal MPO, elastase, MMP8, causing more ROS, lipid peroxidation, DNA damage, breaking down the extracellular matrix. And this isn't just local. These activated neutrophils circulating can cause remote organ injury too.
Compartment syndrome is a classic example for us.
Absolutely. Muscle swells in that tight fascial space, pressure skyrockets, crushes the microcirculation, less oxygen, pH drops, more swelling, more hypoxia, oxidant stress, vicious cycle.
And the anterior compartment peroneal nerve. Time is
very critical. Nerve damage can happen relatively quickly.
What's happening inside the cells during all this, metabolically?
It's chaos. ATP plummets. Cells switch to anaerobic metabolism, make lactic acid, pH drops. Ion pumps fail, sodium builds up inside, water follows. Cells swell. Calcium floods in.
And high calcium is bad.
Very bad. Activates damaging enzymes like calpains, messes up mitochondria. Gene expression also goes haywire, HIF1 alpha, VEGF, NF-kappa B. Inflammatory genes get turned on.
And what about circulating factors, things in the blood?
Yeah, superoxide radicals from enzymes like xanthine oxidase can cause systemic damage. Pro-inflammatory eicosanoids get released. Adhesion molecules go up systemically. It all links together and might even connect to the chronic oxidative stress we see in PA patients.
Wow. So IRI is this incredibly complex cascade affecting cells, tissues, and even remote organs. Understanding it is key to managing these acute situations.
Absolutely essential knowledge for intervening effectively and trying to mitigate the damage.
Okay, building on that challenge of ischemic tissue, Chapter 7 looks at the flip side, therapeutic angiogenesis and arteriogenesis, trying to grow new vessels.
Yeah, a really important area, especially for patients with CLI, critical limb ischemia, who aren't candidates for traditional revascularization.
That progression from PA to rest pain, tissue loss. It highlights that the body's own attempts at neovascularization growing collaterals, angiogenesis, often just aren't enough.
And the consequences are devastating. Amputation, poor quality of life, high mortality, huge costs. So the need for better treatments is urgent.
Standard care risk factors, exercise, meds helps, but isn't enough for severe cases. Endo and open surgery are the mainstays.
Right, but for that no-option group, biologic therapies are the hope, trying to stimulate vessel growth.
The chapter mentions growth factors like VEGF, FGF, HGF.
L1HIF. Yeah, factors known to promote angiogenesis in lab studies. Table 7.2, list a bunch.
Well, translating that into clinical success has been tough. Trials like Talisman, Tamaris.
Mixed results, exactly. Very challenging to get consistent benefit in humans.
Yeah.
Delivery, dosage, patient selection, lots of variables.
What about cell-based therapies, EPCs, bone marrow cells?
Also a major focus.
Huh?
Using endothelial progenitors or a mix of bone marrow-derived cells. And then there's arteriogenesis, focusing on enlarging existing collaterals.
That's driven by shear stress changes, right? Due to the upstream blockage.
Precisely. The increased flow through those pre-existing connections triggers remodeling and growth. But again, the same risk factors that cause PA can impair this natural process too. Figure 7.4 shows that nicely.
So back to therapies. Gene therapy, delivering VEGF or FGF genes.
Tried in trials like Eurostar, Traffic, Famous. Again, some promising signals, but overall mixed success. Not a home run yet.
Molecular therapies, targeting specific proteins or RNAs.
Yeah, things like DEL1 protein, specific microRNAs like miR126, miR-132, long non-coding RNAs, trying to fine-tune the signaling pathways involved in vessel growth.
Yeah.
Still mostly preclinical or early phase.
What about the cell therapies in more detail, EPCs?
Mobilizing them from the bone marrow with GM-CSF, like in the START trial, saw a temporary increase, but a big placebo effect too. Injecting specific cell types like CD133 plus cells after angioplasty has also been looked at.
And bone marrow-derived cells, BMCs, that's a mix of cells, right?
Yeah, various stem and progenitor cells, they might differentiate directly, but also release helpful paracrine factors.
What did the trials like Provasa show?
Some encouraging early results in CLI patients, improvements in ulcers, rest pain, walking time, perfusion markers after injection. But translating that into consistently better amputation-free survival or ABI changes in larger trials has been difficult.
So maybe combining BMCs with other things, growth factors, scaffolds.
That's the thinking now. Combination products might be needed to get a more robust effect. It remains a challenging field trying to effectively stimulate vessel growth in diseased limbs.
Definitely. Okay, so from trying to grow new vessels, let's go back to the physics of flow in the ones we have. Chapter 8, Arterial Hemodynamics.
Yes, absolutely fundamental. Understanding the forces governing blood flow is key to understanding both normal function and disease.
The chapter starts with the basics. Arteries distribute blood, regulate pressure and flow.
Through multiple mechanisms, myogenic response of the muscle itself, metabolic signals from tissues, endothelial control, plus that longer-term adaptation, remodeling in response to stress.
And that classic figure 8.1 showing how the pressure wave changes shape from the aorta down to the periphery.
Crucial visual. And how occlusive disease totally disrupts those normal patterns.
Then we get into the physics concepts, resistance,
Pressure drop overflow, and Poiseuille's law.
Q8 Oriental, that radius to the fourth power.
Exactly. Tiny changes in radius have a huge impact on resistance and flow. An absolutely critical concept.
Then flow itself, velocity profiles.
Wall shear stress again.
Yep. Fortua or a tangential force. We keep coming back to it because it's so important biologically.
What about stresses on the wall? Circumferential stress.
Laplace's law. P times R over wall thickness, roughly, explains why aneurysms are prone to rupture as they get bigger. Axial stress, too, from tethering.
Compliance, stiffness,
Yeah.
how stretchy the arteries are. Determined by elastin-collagen ratio, wall thickness. It's nonlinear, as shown in figure 8.5. Affects how pressure waves travel.
And blood viscosity, how thick the blood is.
Important too, friction between layers. Changes with hematocrit, flow rate, especially relevant in small vessels or near stenosis.
The section on wave propagation is really interesting. Pulse wave velocity. Reflection.
Yeah, PWV tells you how fast the pressure wave travels faster in stiffer arteries. And when that wave hits a branch point or narrowing, it reflects back.
And those reflections add to the pressure wave.
Exactly. Changes its shape, explains why peripheral pressure waveforms look different from central aortic waveforms. The augmentation index quantifies that reflection effect.
Which connects to aortic stiffness and hypertension.
Right. In young people, the aorta is compliant. Reflections come back later. Pulse pressure amplifies towards the periphery.
Right.
With age, the aorta stiffens, PWV increases, reflections return during systole.
Pushing systolic pressure up higher centrally.
Precisely. Reduces that normal amplification. Central stiffness, measured by PWV, becomes a key indicator of cardiovascular risk. Wave intensity analysis helps dissect these forward and backward waves.
And mechanotransduction comes up again, cells responding to forces.
It's central. Shear stress, stretch, influencing cell behavior, ECM turnover, growth, death. There's this feedback loop in hypertension stiffening affects hemodynamics, which promotes more stiffening. Figure 8.12 illustrates that.
Finally, computational modeling, using imaging to simulate flow.
Huge potential. Creating patient-specific models from CT or MRI, applying physiological boundary conditions, lets you analyze flow patterns, shear stress distributions,
Applications.
understanding disease mechanisms, optimizing stent design, planning surgery, maybe even non-invasive diagnosis down the line. Tools like Vascular or Crimson are making this more accessible.
So from basic laws to cutting-edge simulation, understanding hemodynamics is crucial for a vascular surgeon.
Couldn't practice effectively without it. It explains so much of what we see.
Okay, let's switch from arteries to veins. Chapter 9, venous thrombosis, CVI, and other venous issues.
Right, a whole different set of problems, different pressures, different pathophysiology often.
Starting with DVT, deep vein thrombosis. Virchow's triad is still the cornerstone, right?
Stasis, hypercoagulability, endothelial injury dysfunction, usually a combination of factors.
The chapter touches on the coagulation cascade.
Briefly, yeah,
Yeah.
figure 9.1, that complex pathway to fibrin formation and the role of platelets,
Initial plug formation, VWF, GPI-ABIA.
releasing prothrombotic stuff, exposing phospholipids. The chapter notes circulating tissue factor might be particularly important in triggering venous clots, perhaps more so than in some arterial settings.
But the body fights back, natural anticoagulants.
Absolutely. Antithrombin, boosted by heparin, the protein C system with protein S inactivating factors, VAL-MAF, TFPI, heparin sulfates on the endothelium, all working to keep clotting in check.
And breaking down clots that do form, thrombolysis.
Plasminogen deplasmin, which chews up fibrin, also interferes with platelet adhesion, but that's regulated too.
By inhibitors like PI1.
Exactly. Plasminogen activator inhibitor 1 keeps fibrinolysis from running wild. There's even a PI1 polymorphism linked potentially to VTE risk.
And inflammation links into thrombosis here too.
Big time. It's bidirectional. Inflammation activates endothelium, promotes cell adhesion. Leukocytes, platelets get activated. Neutrophil extracellular traps, nets, seem important in venous thrombi. Molecules like galectin-3 too.
What happens after a DVT forms? Resolution.
It's not just dissolving. There's significant vein wall remodeling. Inflammation, leukocytes come in, first neutrophils, then macrophages. Enzymes like MMPs get activated, breaking down elastin and collagen early on.
Can that lead to long-term problems? Stiffness, fibrosis?
Yeah, seems linked to the late consequences like post-thrombotic syndrome. Maybe modulating MMPs could influence that outcome.
Which brings us to CVI, chronic venous insufficiency, the long-term outcome.
Right. Historically called post-thrombotic syndrome. Theories evolved from tissue hypoxia to fibrin cuffs around capillaries to leukocyte trapping being key drivers.
What about varicose veins? Are they just cosmetic?
Mostly, but there's underlying pathology. Hydrostatic pressure is a factor, but also disordered wall structure, altered vasoreactivity. Maybe a primary wall defect contributes. Risk of DVT seems low, maybe because the endothelium still works okay despite slow flow.
In the later stages of CVI, skin changes, ulcers.
Stasis dermatitis, fibrosis, likely driven by the sustained venous hypertension, ongoing leukocyte activation, maybe abnormal healing responses. The vein wall fibrosis itself could damage valves further.
The chapter also mentions thrombophlebitis.
Superficial vein inflammation, sometimes linked to DVT.
Yeah.
And venous aneurysms, rare, but risk of clot and emboli.
So a whole spectrum of venous disease, from acute clots to chronic insufficiency.
Exactly. And understanding the underlying coagulation, inflammation, and remodeling processes is key to management.
Absolutely. Taking all these chapters together, 1 through 9, it really drives home how vital this basic science foundation is.
It really does. And for you listening, it's crucial to see this isn't just, textbook stuff you memorize and forget.
Right.
A solid grasp of these principles, research methods, vessel biology, atherosclerosis, IRI, angiogenesis, hemodynamics, venous disease, it's the bedrock. It informs everything.
How you interpret a study, how you understand what's happening with your patient.
How you evaluate new technologies, new drugs. It empowers you to think critically, to understand the why, not just the what. It lets you provide the best care, truly.
It's the toolkit that allows us to adapt and evolve as surgeons.
Couldn't have said it better. It's absolutely essential throughout your entire career.
Okay, so final thought then. Considering this incredibly complex interplay of basic science, all the signaling, the mechanics, the inflammation we've discussed, especially how pathways overlap between arterial and venous disease, how might future research, maybe focusing on personalized medicine?
Like looking at individual genetic or molecular profiles.
Exactly. How might that kind of personalized approach totally revolutionize how we prevent and treat the whole spectrum of vascular disorders, from the earliest plaque to chronic venous problems in the years ahead? Something to think about.